Okay, so let's move on to another chapter in this module, and it's about opioid agonists. And when we say opioid agonists, it's opioids that stimulate the opioid receptors, compared to opioid antagonists, a medication such as naloxone, which blocks the opioid receptors. Okay. So what do we typically use opioids for? Well, pain would be by far the most common reason for using an opioid. And what do we use an opioid antagonist for? Typically for an opioid overdose. So naloxone we'll talk about in terms of using it for significant opioid overdoses. Okay? So now, whether we're going to talk about morphine, fentanyl, methadone, codeine, hydromorphone, they're all opioid agonists. They all do the same thing. The only difference between them is typically the potency, meaning milligram for milligram, which one is stronger, and the duration of how long each one works. But they're all opioids. Okay? Now, how do we typically give opioids? Well, if it's someone who's able to take an opioid orally, then we'll often give the medication orally for their pain. If it's someone who's nauseated, vomiting, or in severe pain, and we'd like to have the effect occur even sooner, then we'll choose a intravenous option to get the medication into them. If it's someone in chronic pain, then we may choose a fentanyl patch, which releases small amounts of fentanyl over the span of the duration of the patch, which is typically 72 hours before it needs to be changed again. So different options of how to administer the different opioids, whether it's oral, intravenous, or as a patch. They would be the most common routes for opioid administration. Okay, so very briefly on this slide, where do opioids come from? Well, they come from the poppy plant, right? So the seeds of the poppy plant. So opium is the natural is the natural way of obtaining opioids. Okay. So again, we're going to talk about the ways of treating pain, typically starting with medications that don't have the same strength as opioids and the same potential for side effects. So acetaminophen, non-steroidal anti-inflammatories for mild pain and into even moderate pain. And then for moderate to severe pain, we would consider using an opioid to treat the pain. Okay? So remember them as a group though. They're all going to have very similar side effects and nursing considerations. Okay, so what's an opioid agonist? I think we've mentioned this before, but it's a medication that will directly attach to the opioid receptors and produce the same response as any opioid. So morphine, methadone, codeine, they all are opioid agonists, and they directly attach onto the opioid receptors throughout the body and have their positive effects and also negative effects. What's an opioid agonist antagonist, or what we call a partial agonist is a medication that binds to the opioid receptors, but only partially. And it will have just a partial response compared to a full opioid agonist. And we'll talk about a medication that does that called buprenorphine, which we've already spoken about, but it has partial effects. So it will never have the same effect as a full opioid agonist. And then lastly, an opioid antagonist. And really, we're going to talk about naloxone in this group, which blocks the opioid receptors, allowing for reversal of an opioid overdose. And that would be the main reason for using naloxone. So let's just talk about some general principles of pain management. So we often look for alternatives prior to initiating, for example, opioid medications. So non-pharmacologic approaches are becoming more and more common and encouraged because of the addictive potential of opioids and also the adverse effects of opioids that we'll get into. So combining therapies can be very effective, such as physiotherapy, meditation, acupuncture for pain, can be very helpful, even if it just reduces the amount of medications that are required. Okay? So it's not only avoiding the potential for abuse and addiction, but it's also avoiding the adverse effects of sedation, constipation, itching, nausea, and many other side effects that come with opioid medications. Okay? And remember, the whole goal of whether it's non-pharmacologic treatment or pharmacologic treatment with acetaminophen, NSAIDs, and of course the opioid group is to allow the patient to have reduced levels of pain and perform activities of daily living, which we all want to do, right? Eating, getting dressed, walking, all the activities that we want to do throughout the day. So the other concept is trusting people with their pain level. They know their pain the most. So when we ask someone what their pain level is as a pain score, is that useful as a single number on a scale of 1 to 10? Not particularly, because everybody experiences pain differently. But as we give them medication going forward, it can be very useful knowing that their pain went from, say, an 8 to a 5 with interventions that we've done. So asking someone a pain score can be very helpful, especially when following the amount of pain that they have. Okay, I won't spend much time on these non-pharmacological therapies. Many people access these different therapies for either acute pain or chronic pain, right? So you can see massage there. That's very common for acute back spasms, acute back pain. Meditation can be very useful for chronic ongoing pain. In fact, equally as effective as opioid analgesics. So an assortment of different non-pharmacologic therapies that are very useful. So what are the physiological actions of opioids when they attach to opioid receptors? Well, the first one, and the one that we take advantage of the most in terms of its usefulness, is analgesia, so pain control. We can also use opioids to try and suppress a cough. For example, codeine syrup is sometimes used to suppress a cough. Slowing gastrointestinal motility. So somebody who has ongoing chronic diarrhea, we will sometimes use a type of opioid to slow them down, right? So because opioids are constipating, somebody who has chronic diarrhea and we've investigated it and can't find any particular cause, we now try to treat their symptoms, and often adding an opioid to slow down motility is part of that treatment. We use opioids for sedation, not directly for sedation, but often in combination, say with a benzodiazepine, which are very sedating. We use it for procedures. So for example, if someone has a shoulder dislocation, we'll often combine intravenous opioids, which of course have analgesic effects and some sedative effects, plus an intravenous benzodiazepine to heavily sedate them so that we can relocate their shoulder. Okay? Opioids have a very euphoric effect. They make people feel good. So that's the potential disadvantage and why they are abused or potentially abused. Remember, most people that are taking opioids are not taking them with the intention of abusing them. Okay? And lastly, there's intense relaxation with opioids. Whenever we give an intravenous opioid, you should always be thinking of airway and breathing as an adverse effect. So airway and breathing reduction, decreased breaths, decreased respiratory rate, decreased level of consciousness, and of course, decreased blood pressure. So it can lead to hypotension. And we'll talk about that again. So this slide's on acute versus chronic pain. This will be covered more in another semester, but it's important to know a bit about acute versus chronic pain when we're using pain medications, whether it's acetaminophen, non-steroidal anti-inflammatories, or opioids. Okay, so acute pain is typically a useful pain. It's warning you of damage to tissue. Okay, so it doesn't usually last very long, but it's warning you that you've put your hand, for example, on a hot stove, or you have a splinter in your foot, and it's telling you, do something about it. Okay, so it's a productive pain, and it rarely leads to any long-term psychological effects. It can lead to short-term anxiety and sleeplessness because of the pain, but typically acute pain comes to an end, and it was very useful to experience it, although the person doesn't usually feel that way, because it warned the patient to do something about either the injury or the painful area of their body. Okay? Chronic pain tends to be less useful as a warning signal to the patient. There's typically no ongoing healing any longer, but the pain continues. It's not warning the patient to, say, withdraw their hand from a hot stove. It's just a chronic pain signal from the nerves or from a certain area of the body, such as the lower back, that is harmful over time. And it's harmful in a psychological way because chronic pain is often associated with depression, social withdrawal. You don't want to do activities with other people when you're chronically in pain. And we think it's a dysfunction of the central nervous system signaling from the area. So if you have chronic abdominal pain or chronic back pain and there's no cause found, unfortunately, this can last for years and be very disabling from a psychological point of view and from a activities point of view. People in chronic pain have reduced level of functioning, whether it's at home or at work. Okay, so just a brief slide on types of pain. So somatic pain is the pain that you would think of from soft tissues, muscles, joints when they get injured. Okay, so it's a very well localized pain. When you cut your finger, for example, you know exactly where the pain's coming from. And this type of pain responds very well to analgesics, whether it's the acetaminophen group, the NSAID group, or if necessary, the opioid group. Visceral pain is typically, it's less of a specific pain. It doesn't directly tell you where the pain is coming from. And an example would be appendicitis, where initially you just have generalized dull abdominal pain. It's not localized anywhere yet. So visceral pain typically refers to the organs, and it's not as I said, specifically localized. Again, it responds well to analgesics. Neuropathic pain is pain that comes directly from the nerves themselves. So the nerves have either been injured or they've been damaged over the years, say from a chemotherapy drug or from diabetes that causes nerve damage because the little tiny blood vessels that were feeding those nerves have been blocked by diabetes over time. And now the nerves are permanently damaged and they release signals called neuropathic pain. And this is typically a burning, shooting, numb type pain. And rarely does this respond to acetaminophen, non-steroidal anti-inflammatories, or even opioids. It typically responds to medications that we use for seizures, such as gabapentin or pregabalin. Because if you think about it, the nerve is coming from, the pain is coming from the nerve itself. So if we can settle down the activity from the nerve with anti-seizure medications, then it would be potentially effective in reducing the pain. Okay, so that is the reason why you're going to see gabapentin, pregabalin, amitriptyline used as medications to control neuropathic pain. Okay, so let's talk about some pharmacologic therapies for pain control. So we typically break analgesics into two broad groups, opioids and non-opioids. And the opioids are all the ones that we've just spent a bit of time talking about. Morphine, codeine, hydromorphone. Those are all opioids. The non-opioids are typically acetaminophen and all the non-steroidal anti-inflammatory medications. So for minor to moderate pain, so typically something like dental pain, maybe a minor injury, we use non-opioids. They don't have any addictive potential, and they're very effective for minor to moderate pain. Okay, so acetaminophen and NSAIDs are the groups, and we often combine them together. Then, as the pain increases, so conditions, so acute painful conditions, an example would be a kidney stone, or a severe injury, a broken bone, anything that requires a higher degree of pain control, we can use an opioid. And often we'll add an opioid to acetaminophen or a non-steroidal anti-inflammatory. Okay? In fact, many opioids are combined with acetaminophen in a fixed dose pill. So that's always important to remember for the patient, since they're getting acetaminophen in the pill that has the opioid already. So if they're taking acetaminophen as well, then they have to make sure that they're not getting beyond the 4 grams total per 24 hours. Okay, so that's important to remember, that many combination medications have acetaminophen with an opioid in one pill, and that you can easily get to 4 grams per 24 hours of acetaminophen if you're taking, say, for example, 2 extra strength acetaminophen, which they're 500 milligrams each, so that would be 1,000 milligrams of acetaminophen per dose. It wouldn't be hard to imagine getting to 4 grams per day, which is 4,000 milligrams. Okay, so this slide is just showing an opioid, whichever one. We'll use morphine as an example, attaching to an opioid receptor. And the opioid receptors are in the brain, they can be in the bowel, they can be all over the body, and that's how you get your adverse effects from the opioid, from receptors all over the body. So remember, when we're thinking of opioids, whether we're talking about morphine or codeine, think of them as a group, because they can all lead to the same adverse effects. So what are the very important adverse effects? Respiratory depression, right? So we monitor the vital signs with anyone receiving high doses of opioids, or definitely intravenous opioids, okay? And we also would consider having naloxone nearby and resuscitative equipment at the bedside if someone was receiving intravenous opioids. And we rarely combine sedatives such as benzodiazepines because of the additive sedative qualities of both of them. Orthostatic hypotension, so getting up too quickly, can lead to low blood pressure. And that's because opioids can vasodilate the blood vessels. So when you suddenly stand up, your blood pressure that hasn't had time to accommodate and get back to a normal pressure, so it drops. And you have orthostatic hypotension, which can lead to falls and injuries. Constipation, any opioid is constipating, and we often have to add a laxative or a stool softener when starting an opioid medication. Okay. And finally, urinary retention, especially in males, because opioids relax the bladder muscle, so they have less forceful contractions. And if you were already a male with prostate issues, that might be enough to put you into urinary retention. And that often happens after a surgical procedure where you're receiving opioids for pain, and now it's realized that you're unable to urinate. Okay? So when considering that, it's important to monitor the input and output of urine. Monitor for the patient's comfort or the urge to urinate but unable to urinate. Okay? So monitoring output's important so that you know that the person isn't retaining urine in their bladder. And it would be the same thing for constipation, right? Knowing how often the person is having a bowel movement to decide whether, yes, you are becoming constipated, we should do something about it, such as increasing fluid intake, fiber intake, and potentially stool softeners or laxatives. Okay, so patient-controlled analgesic infusion pumps, so a PCA pump, often used post-surgical, can be used in palliative care settings where someone's on a ongoing dose of opioids, such as morphine, and then they also have the option to press a button to have extra doses infused for pain control. So it gives the patient a certain degree of control over how much opioids they're receiving, right? So there's a background amount per hour, and then they can choose to have more by pressing the button, which the machine will release more opioids. And it'll be a set number of times they can press it per hour. Okay, so let's get into an opioid agonist, and the prototype will be morphine. We can talk about buprenorphine, which we've already spent some time talking about, but it's here only because it's a partial agonist. And then, of course, naloxone is a full antagonist. Okay, so we'll keep on moving here. We're almost done. Okay, so when you think of opioids for pain control, think of the very, very common side effects. And all of these are common. So the oversedation, the respiratory depression, the potential for hypotension, the very common constipation and nausea and vomiting. Itching is common on opioids, and so is urinary retention. So these are all common to the entire group, not just one opioid, but the entire group. Okay, so let's talk about a prototype opioid medication. And morphine really is a prototype. And remember, the indications for opioids will basically be the same. The adverse effects for opioids will be the same. Just like when we talk about benzodiazepines and having very similar adverse effects and effects, the same goes for any opioid. They all basically have the same indications and adverse effects. Okay, so how do they work? Well, they attach to the opioid receptor, the mu receptor, or the kappa receptor, and address the symptom of pain. And we use them in severe or in moderate to severe pain, and sometimes to reduce bowel motility for chronic diarrhea, but mainly it's the first indication, moderate to severe pain. Okay. So what are the common adverse effects? So let's go through the relatively minor ones first, but they're still common. So itching. Well, opioids release histamine in the bloodstream, leading to itching. Constipation. They're very constipating, as I've mentioned on a previous slide. Hypotension. Okay, in particular, orthostatic hypotension. When you get up too quickly, because these drugs vasodilate the blood vessels, when you stand up, your blood pressure drops and you get dizzy and have the potential to fall over. Urinary retention. By relaxing the bladder muscle, you may not be able to empty your bladder anymore. And nausea and vomiting are extremely common with opioids, any of them. Okay, they're often one of the most limiting symptoms for opioids. Now, let's get into the more significant side effects. So definitely when used in large doses or intravenously, respiratory depression, apnea can occur. And respiratory depression can be significant. So when we're using IV opioids, we often have Narcan available, or we have resuscitation equipment out, such as a bag valve mask in case we have to breathe for someone. Remember that opioids give you pinpoint pupils, okay? And so when someone comes in with an opioid overdose, not only are they not awake any longer, they're in a coma, and they're breathing very slowly, but they typically have pinpoint pupils when we look at their pupils, okay? There's very few contraindications to opioids unless you have an absolute allergy to one of them. That would be one of the most common. Sometimes we'll avoid opioids during delivery during labor to avoid having the infant have opioids on board after delivery. But for the most part, they're tolerated well and for their analgesic effect. But we just have to be aware of the common adverse effects. Okay, so in terms of nursing care, checking blood pressure, checking respiratory rate, checking level of consciousness. Are they over sedated before getting the next dose? Checking for urinary retention and significant constipation. Big issue. Okay. Assessing their level of pain. How effective is the dose they are receiving for the pain? And lastly, always thinking of what will I need to do if someone has received an excessive dose. Well, it's always assessing the patient first. So it's going to be airway, breathing, and circulation. Circulation will always include a blood pressure, an O2 sat monitor. So, and of course, having naloxone available if an excessive dose of opioids is given. Also remembering that these are CNS depressants, so any other drug that will also suppress brain activity, such as the barbiturates, the benzodiazepines, alcohol, they will be additive to these drugs. Anticholinergic drugs, so any medication that has anticholinergic side effects, one being sedation, will also be additive to these medications in terms of being over-sedated, right? So when you hear anticholinergic, what are the main symptoms? Sedation, dilated pupils and blurry vision, dry mouth, constipation, urinary retention, okay? And the use of opioids when someone is on an antihypertensive medication, both have the potential to drop their the patient's blood pressure. So just need to be a bit careful when using opioids with someone who's on antihypertensives, since both will reduce the blood pressure. Now, when we're giving opioids intravenously, we don't usually push them. We give them over minutes, sometimes 5 to 10 minutes, okay? If you push an opioid, you can make someone apneic and significantly reduced respiratory rate, okay? So it increases the chance that you'll have to resuscitate them or use naloxone, for example, if you pushed an opioid. And lastly, remember, we've been talking about pills, which most of these come in a pill form, except for fentanyl, which comes intravenously or as a patch, a transdermal patch. A lot of these come intravenously. The main one that we use intravenously would be fentanyl, morphine, and hydromorphone, which is dilaudid. In the patch form, it's really fentanyl, and it's applied for 3 days and then removed. And then another patch is replaced on that 3rd day. And typically, it takes time for a fentanyl patch to start to be effective. So it won't work immediately. It has to get through the skin into the bloodstream. So it's not unreasonable to start someone on a short-acting opioid at the beginning when they're starting a transdermal fentanyl patch for ongoing pain. Okay, so let's look at this drug for a bit. It's called tramadol, and I wouldn't say it's an overly popular drug. You will definitely see it being used though. It's considered an opioid analgesic, but it also has another property. And if you look under action, yes, it activates the opioid receptors, those mu receptors. So it acts as an opioid analgesic for pain, but it also acts basically as an antidepressant. It inhibits the reuptake of norepinephrine and serotonin, and that's what antidepressants do. So it's a bit of a messy drug. It's an opioid agonist, and it's a bit of an antidepressant, and so this mixture gives it all kinds of weird side effects. So a lot of us don't use it very frequently. Okay, we just will use straight opioid analgesics such as fentanyl or morphine or hydromorphone. Okay, I would still consider this one an opioid analgesic. It just has this really weird other effect that acts as an antidepressant. If you look under the adverse effects of tramadol, they're all the opioid side effects. Itching. Just if you know one opioid, you know them all. Okay. All of these are super common with any opioid: morphine, fentanyl, hydromorphone, codeine. They all cause itching. If in excessive amounts, respiratory depression. They all cause constipation. They can all cause hypotension, urinary retention. They can be very sedating and cause dizziness. Nausea and vomiting are super common with opioids. Okay? And remember what someone looks like when they're toxic on an opioid. They have pinpoint pupils. So we always check the pupils if someone comes in unconscious, breathing very slowly. We see if their pupils are pinpoint, and if they are, we'll definitely suspect an opioid overdose. And we can use the reversal agent called naloxone. Okay. Notice under adverse effects, serotonin syndrome. So that's where that weird secondary action is taking place, that it's a norepinephrine and serotonin reuptake inhibitor. Okay, and that's why it can also cause seizures, because of this secondary action that it has. So it's a messy drug. Okay. I won't go into the contraindications, but if you know the fact that it's a bit of a messy drug, that it's an opioid analgesic and kind of this antidepressant all mixed in one, you'll see that under contraindications, to avoid use with all the other antidepressants. Well, that makes sense because you may get serotonin syndrome from it, right? Why would we avoid alcohol? Well, because of the opioid component to this drug. Why a high fiber diet? Constipating with opioids, right? This you can also develop tolerance and dependence to this drug because of the opioid component. Okay, I hope that helps. Okay, so this slide is just a reminder to you or some information on a partial agonist. And really the one that we spoke about is buprenorphine. And we can use this medication to treat moderate pain. It still has opioid effects, but just partially. So it won't be as strong as a full opioid such as morphine. It'll definitely have less respiratory depression, less potential for abuse and dependence, and less potential to actually overdose on it. And that is partly why we use it to help patients with opioid withdrawals and also maintain them on this medication instead of taking illicit narcotics or opioids, which are much, much more dangerous. Okay, so buprenorphine is really the one that we've started to use more and more. Methadone is still available. Clonidine can still be used, but this one's becoming more and more popular because it's a partial agonist, so it takes away those withdrawal symptoms, and then we maintain them on this medication until it's gradually tapered, and it's just much safer than methadone. So we won't go over this slide again. We've already reviewed buprenorphine and buprenorphine with naloxone and the reasoning why naloxone is added to it. So it's in the upper part of this module, so I'll let you lead or listen to that voiceover if you need to. This is just a reminder that everybody gets sick, right? So no matter how you look, we always need to remind ourselves that everybody gets sick, everybody gets pain, so minimizing judgment. And always remember that, because it's easy to judge when someone says they're in miserable pain and you're deciding that they don't have pain. And sometimes our brains work that way, but remembering that everybody has the ability, unfortunately, to get sick and to have severe pain. Okay, and lastly, let's talk about naloxone, which is the reversal agent for opioids, whether they're prescription opioids that were taken in an overdose or illicit opioids, which were either taken orally or IV, and the patient is now in trouble. They have reduced level of consciousness, they're not breathing well, they're breathing slowly, bradypnea, they're hypotensive, so they need a quick reversal agent. So naloxone is really used to reverse somebody with an opioid overdose and to reverse the respiratory depression associated with it. Okay, so someone who is becoming hypoxic or is unconscious from an opioid or hypotensive from an opioid, we would use naloxone to reverse those effects. Not just someone who's a bit sedated with naloxone, but someone who's having profound effects from the naloxone. And sometimes we'll use small doses, but frequently, until we see that they're starting to breathe again and that their blood pressure is coming up. But in particular, the improvement in the respiratory status. Okay? Because Without improvement in the airway and respiratory status, they will need to be intubated. Okay? If we gave large doses of naloxone all at once, we could reverse completely somebody's chronic opioid addiction and put them into acute withdrawal, which we try not to do because of the severe withdrawal symptoms they'll have to endure. And then we may even have to give them an opioid to reverse their acute withdrawal. So we give naloxone, but we can give it slowly and watch the respiratory rate improve. Okay, so last slide on naloxone. So this is it really is the prototype. Naltrexone is it's the oral one that we can use to try and convince people to stay away from opioids or alcohol. So it's for abstinence, but naloxone is the intravenous reversal agent for opioids. Okay. So again, for opioid-induced respiratory depression, reduced level of consciousness, anything that the body has significantly been impacted in a respiratory or cardiovascular or central nervous system effects of the opioid can be reversed with this drug. Now, if we reverse someone too quickly, look at the adverse effects. So we've suddenly woken them up. So the brain suddenly wakes up. It could have seizures. They will be tachycardic, hypertensive, diaphoretic, nausea and vomiting. Those are all just reversal. They are the withdrawal symptoms of too much naloxone because you've suddenly replaced all the opioids that were in their body with naloxone. Okay? So when we give someone naloxone intravenously, we may need to be prepared to give them something as a sedative if they get too much naloxone because they'll be very agitated. Okay, so sometimes we may have to give them a benzodiazepine later once they've been reversed and they're waking up. Okay, so we use slow doses unless it's an absolute emergency that requires immediate reversal. And also remembering many opioids can last longer than naloxone. So once we reverse them with naloxone, we will still need to observe their respirations and blood pressure for hours longer because the naloxone can wear off and their opioid is still hanging around in their bloodstream, and they can go back into respiratory depression and reduced level of consciousness. So we're going to begin talking about substance use disorders. And this is a huge problem in the United States, whether it's alcohol, prescription medications, or illicit medications. All are creating significant health issues for patients and their families, of course, since they're often the ones that suffer as well with having somebody at home that's addicted to an illicit drug or a prescription medication. So on this slide, we're seeing some drugs that are illicit and some that are prescription and some that are easily obtainable at a store. So cigarettes and alcohol, easily obtainable, both have a lot of addiction and health concerns with them. Cigarettes, as you can imagine, is a big health issue, ranging from COPD, lung cancer, heart disease, hypertension, kidney cancer, stomach cancer, esophageal cancer, bladder cancer, a variety of issues. And I didn't even mention stroke in that for cigarette smoking. So there's so many issues with cigarettes. Alcohol, number 9 killer in the United States. Alcoholism and typically leading to cirrhosis. In the background there, prescription medications, so whether they're benzodiazepines or even more commonly opioid medications that can be abused. And then, of course, illicit medications more in the front, the powder. Okay, so we're going to talk about a number of these different addictive medications, whether they're illicit or prescription. So when we look at alcohol and opioids, they're a huge problem. So look at the amount of people that die each year from alcoholism. It's approaching 100,000, and that's not including the patients that are suffering due to chronic alcoholism, liver cirrhosis, all the family issues that it creates being addicted to alcohol. When we look at opioids, a huge percentage of the world's opioids comes to United States and Canada. So we make up 5% of the population, but consume approximately 80% of prescription painkillers. So really big issue, opioid use and opioid addiction. Okay, so we're going to talk about some medications. So typical opioids you're going to hear about, such as morphine, hydrocodone, oxycodone, and then we're going to talk about fentanyl. So an assortment of different opioids. Essentially, an opioid, they're all very similar in side effects. It's the potency of the different ones that matter, and we'll talk about that going forward. Okay, what about recognizing some typical characteristics of substance abuse? So the craving of the substance from the patient. So this is typically the physical dependence, right? So as you withdraw from a medication, the craving begins and the desire to seek out more of the medication becomes stronger. With any illicit drug or prescription drug, as it becomes more and more abused, there's typically difficulty maintaining relationships at home and at work, right? So it's not just the addiction to the drug, it's also maintaining your normal lifestyle, which is now being harmed as well. So the work and the home relationships are suffering because of it. There's an increased tolerance to the medication, which is very typical for illicit substances or prescription substances that you can develop a tolerance for, meaning you need more of the medication to have the same desired effect. Okay, so the dose and the amount gradually goes up. either month after month or year after year, you require more. A lot of difficulty quitting. So many unsuccessful attempts to quit, but many patients find that that's the case with cigarettes or alcohol. But I just tell them there's no problem trying to quit and realizing that it's not the right time and then trying again and being successful. So always giving yourself a bit of leeway in terms of it's not a failure to try to quit. It may have been unsuccessful, but you always have the ability to try again. Recognition of behavioral changes when the substance is discontinued. Well, that's the withdrawal symptom, right? So we're going to talk about an alcohol withdrawal and what we typically see, the physical changes and the behavioral changes that occur, and the physical changes are very, very typical when we're talking about opioids or if we're talking about alcohol. There's a certain progression depending on the amount that the patient has been consuming, whether it's opioids or alcohol. There will be a somewhat predictable withdrawal pattern or symptoms that will occur once the medication or substance has been stopped. Okay, so the term addiction, so the overwhelming compulsion to seek out the drug or the medication, even despite the health consequences and the social consequences, whether at home or at work, right? The physical dependence, the symptoms that will occur once the medication has been stopped or reduced, and we'll talk about the different withdrawal symptoms that occur. And then the psychological dependence, which isn't an overt physical withdrawal, but it's the emotional symptoms that occur once as the medication is withdrawn. Sorry. So the anxiety, agitation, the emotional turmoil that occurs, whether it's an opioid or alcohol that has been stopped. Okay, so alcohol withdrawal and abstinence is what we're talking about. So let's just talk about alcohol a bit first. So alcohol is a direct CNS depressant, central nervous system depressant. So what are the effects of alcohol we expect to see as the level goes higher and higher in the bloodstream? Well, sedation, relaxation, loss of motor control, so falling over, so increased potential for falls, head injuries, disinhibited, meaning you typically will not do certain activities if you weren't intoxicated, but now that you're disinhibited, you may do activities that would potentially put yourself at harm. Okay, so disinhibition occurs with alcohol consumption. Partial to full amnesia, so partial or full loss of the event, loss of memory of the event can occur. What about acute overdose? So when we say acute overdose of alcohol, we're talking about someone who's consumed incredible amounts of alcohol quickly, leading to potential respiratory failure, hypotension, and even going into a coma. Okay, so that is very high levels of alcohol. And typically, when you've consumed that amount of alcohol, your stomach is trying to get it out of you by vomiting. Okay? Now, let's also remember the interactions of alcohol with acetaminophen. Both of them are hepatotoxic. So acetaminophen at levels greater than 4 grams per day can be toxic to the liver, but even lower amounts of that in combination with alcohol can be hepatotoxic because they both impact the liver. Antibiotics, the most common one is metronidazole, which has an interaction with alcohol. It's called a disulfiram-like reaction, and we'll talk about that a bit later. But basically, taking alcohol with metronidazole can make you violently ill, nausea, vomiting, abdominal pain. So patients that take metronidazole are advised definitely not to take any alcohol. Non-steroidal anti-inflammatories. Well, aspirin and non-steroidal anti-inflammatories are irritating to the stomach. They can cause the stomach to bleed or lead to peptic ulcers in the stomach. Alcohol is a direct irritant to the stomach, so in combination, they can lead to a higher chance of gastrointestinal bleeding from the stomach. When we think of alcohol in combination with any opioid, such as morphine, codeine, hydromorphone, any opioid, we need to think that they're also sedating as well. So they're additive to the alcohol. And that goes along with any sedative medication, such as benzodiazepines. So definitely benzodiazepines and alcohol would have an additive effect of sedation and relaxation. And then finally, if taken in large enough amounts together, they can lead to decreased respiratory drive, decreased respirations, and potentially respiratory failure. Okay? So remember, alcohol is just a water-soluble molecule. It easily crosses the blood-brain barrier to have all of its effects on someone's brain. It also crosses the placenta very easily, and can cause harm to the fetus. In particular, there's a syndrome called fetal alcohol syndrome, and we'll likely end up talking a bit more about that later. Okay, so let's just talk a bit about alcoholism and its effects on the liver. So, with heavy consumption of alcohol, what happens is you get a hepatitis, which is really inflammation of the liver. So, with repeated bouts of hepatitis, the liver finally starts to get fibrotic. The liver cells start to die, and they're replaced with scarring, which is fibrosis. And because the liver, like many other organs, is a very durable organ, this will take years to occur, right? So it won't happen in a year or two. It'll happen over years. And finally, when you get cirrhosis, you have reduced number of hepatocytes, so which are the liver cells. Okay, and that's not reversible. That's permanent scarring of the liver. So when you hear of someone donating part of their liver to somebody else, they definitely don't have cirrhosis, because that's not going to grow back. Cirrhosis is a permanently damaged liver. Okay. Because the liver is involved in so many functions of the body, there's going to be many, many symptoms and many signs of cirrhosis, of liver failure. The liver, we'll just mention this a bit because you'll hear it again in pathophysiology later on, but the liver is involved in the clotting factors, producing the proteins that allow your blood to clot. It's involved in all your metabolic functions. So storage of glycogen, metabolism of fats, production of most of the proteins in your body, and also the breakdown of proteins back to amino acids. It stores fat-soluble vitamins. Okay, so your fat-soluble vitamins, A, D, E, and K, are typically stored in your liver. And as well, there happens to be another one called vitamin B12. That's also stored in the liver. The liver is heavily involved in metabolism of medications or drugs. So there's just so many functions of the liver that when you get cirrhosis, a lot of symptoms and signs develop. Okay. What else with chronic alcoholism? Well, in a pregnant mother, we mentioned fetal alcohol syndrome in the infant. So, and again, we'll talk about this at a different time. Let's get on to some medications. So, what medications can we use to help with withdrawal of alcohol? And maybe some medications that can be used to abstain from alcohol. They don't tend to be very effective. We'll talk about a couple. When we talk about withdrawal from alcohol, we're really talking about benzodiazepines. Okay? So keep that in mind. Withdrawal of alcohol, what do we use? Benzodiazepines for the agitation, the restlessness, the tachycardia, everything that you get with alcohol withdrawal can be helped with administration of benzodiazepines. When we're talking about medication that we can try to prevent someone from continuing use of alcohol, that's not withdrawal anymore. That's abstaining from alcohol. And there's a couple such as disulfiram, naltrexone, and another that we'll talk about. They're not overly effective. We'll still talk about them a bit though. Okay? So let's move on from this slide. So here's a typical timeline for alcohol withdrawal. And often, once you have stopped consuming alcohol that you've been consuming for many, many months or years, you can expect a lot of these symptoms to start to occur. So in the first 6 to 8 hours, you're typically facing nausea, vomiting, sweating, insomnia. Remember, alcohol is a CNS depressant. Your brain has become used to being suppressed and inhibited, and now the alcohol is being removed. So you're starting to get a bit more agitated. So the brain is now waking up saying, where's the alcohol that I've had for many months or years? And so that's where the vomiting, the sweating, the insomnia comes from. And then as this continues, 12, 24 hours of withdrawal, lack of appetite. Definitely agitation should be in there because they're typically agitated. Some tremors are starting. The potential for hallucinations is beginning. And then finally, 1, 2, or 3 days later, as you are detoxing from alcohol, that's the potential for delirium tremens that we're going to talk about, which is typically a very, very agitated state, often with psychosis, which typically involves hallucinations. They're typically very sweaty, very confused. And finally, being one of the most serious symptoms and signs is tonic-clonic seizures, right? So the brain has been suppressed for so long by the alcohol that now that it's withdrawn, it's become so agitated that it has led to seizures. Okay, Why the low blood sugar? Well, the liver regulates glycogen storages. So alcoholics are more prone to less storage of glycogen. And when they're in a very agitated state, um, and you have the potential for seizures, you're actually consuming a lot of glucose. So the fact that they have low storage of glucose and they're consuming more glucose because of the state they're in, uh, the potential for hypoglycemia is there. Okay. And here's a slide on delirium tremens, right? So the symptoms associated with it, the severe agitation, confusion, the psychosis, meaning the hallucinations. They're very, very tremulous and often paranoid. So whether they're seeing things on the wall, or they have auditory hallucinations, they're often visual hallucinations actually. It's a very serious condition. They're often tachycardic. They're dehydrated. They're hypertensive. So this is where benzodiazepines are extremely important to settle down all of those symptoms and signs. And sometimes patients are so psychotic that we have to add not only benzodiazepines, but an antipsychotic medication to try and control the withdrawal from the alcohol. Okay? And really, not only do we want to control the delirium part, which you can see in this slide, but we want to control the impending seizures that are going to occur if we don't add benzodiazepines. Okay, so think about withdrawal as really benzodiazepines and sometimes antipsychotics because of the psychosis that they're experiencing. Okay, so let's just spend a minute on this slide. This is alcohol-induced liver cirrhosis. So I mentioned that over the span of years where you get repetitive alcoholic hepatitis, inflammation of the liver, secondary to alcohol consumption, you're finally left with cirrhosis, which is scarring and fibrosis of the liver. And when you develop that, the blood flow from your intestines, such as your stomach, your small intestines, and your liver, and your colon, the blood all returns to the liver through the portal vein. But now with the damage to the liver, the blood can't flow through the liver any longer in the blood vessels. So what you're left with is an inability for the portal vein to deliver the blood properly to the liver and flow through the liver to get to the inferior vena cava and back to the heart. So that the fluid backs up into the abdominal cavity. And that's called ascites. So what we're looking at in this picture is a massive amount of fluid that is unable to return from the intestines through the liver and back into the bloodstream, which is, in terms of the liver, would be the inferior vena cava and then back to the heart. Okay, and you can imagine how uncomfortable this is. And often these patients need drainage of their ascites to remove some of the pressure. It's not going to correct the underlying condition, which is liver failure, i.e. cirrhosis, but it'll take we can drain many, many liters off of someone's abdomen with a simple needle. It's called paracentesis, and it allows them some time that they're not as uncomfortable until the fluid builds up again. Okay, so this is an end stage result of cirrhosis. Okay, so this drug, what do we use benzodiazepines in this? Yeah, when we're talking about alcohol, alcohol withdrawal, right? That acutely agitated state as you withdraw from alcohol, potentially leading to delirium tremens and a generalized tonic-clonic seizure. We want to help people control their severe anxiety and tremors and sweating and all the symptoms they have from the alcohol withdrawal. And it doesn't need to be diazepam. It could be lorazepam or any of the other benzodiazepines. Okay, so when you're studying a benzodiazepine, remember they're all very, very similar. Okay, remember the ending of them. The only one there that really stands out as different is chlordiazepoxide. Okay, that doesn't have a typical benzodiazepine ending, but the vast majority end in ZEPAM or OLAM, alprazolam, diazepam, clonazepam. And the only real differences between any of them is one might last longer than another, one might be a bit more potent than another, but generally they do the same thing. Okay, so they increase the effects of the GABA system, which is that inhibitory neurotransmitter in the brain. So it's going to suppress the brain, it's going to relax the brain. And by doing that, in high doses, it can lead to respiratory depression, apnea, which is lack of breathing. And in high doses, such as an overdose, it will lead to hypotension. And so if someone overdoses on a benzodiazepine, these adverse effects can occur. And what's not included here, by the way, is decreased level of consciousness, right? They're so sedated that they're now on a spectrum all the way to unconscious. So they might be what's called obtunded, meaning they're knocked out, they're rousable, but they're not really be able to converse with you, all the way to being completely unconscious. Okay, so what do benzodiazepines do as bad adverse effects? Decrease respiratory drive, hypotension, and decreased CNS activity, right? Lethargy, sedation, all the way to unconsciousness. Okay, and that's why we tell people, careful with benzodiazepines because they can reduce your level of consciousness, they can reduce your level of ability to focus. So we always advise patients that are on benzodiazepines in terms of doing anything that requires a lot of mental focus. Now, whenever we have someone with an alcohol withdrawal issue, we will definitely have an intravenous line in them because they have the potential to have a seizure, right? And often at the beginning, we're giving intravenous benzodiazepines until they're more stable and able to take benzodiazepines orally. Okay? And then the aim really is to gradually taper them off, reduce the amount of benzodiazepines that they are taking until they no longer need them. So, a patient needs to be cooperative with that. They need to want to stay away from alcohol. So part of this takes place in a hospital. Part of the withdrawal process, once they're stable, would take place out of the hospital. And it would depend on them to see if they are able to stay away from the alcohol. So it often involves some counseling, going to AA, Alcoholics Anonymous, and just getting a lot of support to stay away from the alcohol. Okay, so benzodiazepines, remember, too much of a benzodiazepine, respiratory depression, hypotension, and more deeper sedation. Okay. Okay, so disulfiram. So this drug was typically used years ago. Let's go into a couple of decades ago. Not so much anymore. Okay. It was a pill that someone would take, and it was taken daily. And if they consumed alcohol while on this drug, disulfiram, they would have a violent reaction. Okay, so it was meant as a deterrent to take alcohol. The problem with it is you just needed to stop taking the pill when you wanted to drink. So you would need a highly motivated patient to stay on disulfiram to stop themselves from drinking. Okay? So now we really just refer to it as the term that alcohol can cause with other drugs, such as I mentioned metronidazole. So someone who's taking the antibiotic metronidazole and consumes alcohol, they could have what's called a disulfiram-like reaction, meaning the metronidazole and alcohol interact just like disulfiram and alcohol interacts, and they get ill, vomiting, abdominal cramps, flushing from the interaction. Okay? So a patient that's routinely taking disulfiram can expect these symptoms to occur with a headache, with alcohol consumption: nausea, vomiting, flushing, headaches, uh, abdominal discomfort. That would be an expected occurrence if they consumed alcohol while on it. So really uh, stressing the fact that they cannot take alcohol while taking this medication called disulfiram. Okay, and that's alcohol in anything. Cough syrups can sometimes contain alcohol. Uh, Mouth washes can have alcohol, so it would be any kind of alcohol. And the one thing that we monitor when patients are on this medication is the liver, because it can cause a bit of a hepatitis, which is inflammation of the liver. Not a medication that's frequently used as much anymore. Okay, so here's another medication, naltrexone, that can be used to try and help someone abstain from alcohol or from opioids. This is actually an opioid antagonist. This is not the one that we use to reverse the effects of opioids, which would be naloxone. And we'll talk about that towards the end of this module. So this one is another medication that you can take orally, and it blocks the opioid receptors. So if you were to take an opioid, whether it's illicit, because you were addicted to them, this will block the opioid receptors. But the same issue comes into play, that all you need to do is stop taking this if you really want to take opioids. So if you're not adherent to it and you want to restart taking opioids or narcotics, then it's just a matter of stopping this medication. This medication can also be used for alcohol abstinence. This medication is never used for withdrawal. Okay, it's taken once someone has had withdrawal and they want to try and abstain from alcohol or opioids. Okay, so but again, it's the adherence of the medication that is required, and it can easily be stopped, and alcohol or opioids can be restarted. So if you're taking this for um, opioid abstinence, then all of the opioids have to be completely out of your system before starting this, because this oral medication will go to the opioid receptors and completely block them. So if all of the drugs aren't out of your system, you will go into sudden withdrawal, right? And that's not what you would want to do. So typically this is taken days after you've completely withdrawn from the opioid. It's not in your system at all anymore. Okay? So you'd be looking at 7 to 10 days. And notice an opioid such as methadone is a very long-acting opioid. And we'll talk about that a bit later and the advantage of why methadone is used in clinics, partly because it is a long-acting opioid. Okay? Okay, so just briefly on this medication called acamprosate. A medication, again, used for alcohol abstinence, not withdrawal at all. Withdrawal is benzodiazepines and antipsychotics. So this is meant to be taken to decrease the use and the cravings of alcohol consumption. You can see that there is an assortment of side effects with these medications. Some of these are very likely from the drug, and some of these are very likely from the fact that dealing with alcoholism and dealing with the psychological impact of trying to avoid alcohol can lead to many of these symptoms: anxiety, depression, suicidal thoughts. So it's likely hard to tease out which side effects are from the drug, which side effects are from the actual underlying alcoholism. Okay. Main side effect, well, just diarrhea with this medication, so just maintaining proper fluid intake. This medication can be taken with meals. We wouldn't use this medication in someone who's pregnant. Okay, so again, another one just for abstinence. Okay. Okay, so let's just look at some of the effects of opioids. So whether it's an oral opioid that can start to have its effect probably in about 30 minutes, or an injected or inhaled opioids, which will have effects extremely quickly. They get right into the bloodstream and bind to those opioid receptors. And the effects are often pleasurable for people, right? So there's relaxation, there's sedation, there's pleasurable feelings. So patients that are very agitated or have a lot of emotional pain can derive a lot of comfort with opioids or narcotics. Okay, what are the side effects? Well, and by the way, we're talking about opioid effects and why they're taken, but we're also going to talk about now just some common side effects, but we're going to go into a bit more detail later. So, slurred speech. Typically, people on opioids or narcotics they have constricted pupils, very tiny pinpoint pupils, especially at higher doses. They have reduced level of consciousness, right? As they're taking more and more and they're potentially overdosing, one of the effects is over sedation. Respiratory depression is a big issue with opioid overdose. And that's partly why naloxone is readily available for patients to have at home if they are abusers or not abusers of opioids. If they use opioids, you can now have naloxone at home in case there's an overdose. Ambulances stock naloxone so that when they arrive to an opioid overdose, whether it's an intentional one or not, they can administer intravenous naloxone. Okay. Dependence develops quickly on opioids. Up until a few years ago, we didn't realize how dependence formed so quickly, how someone can become addicted so quickly to opioids. And also tolerance develops quickly, meaning you need higher and higher doses to have the same effect. Okay? Okay, so now let's look at an opioid withdrawal. Okay, so someone who's been taking opioids for months and now they withdraw. So whether it's an illicit narcotic obtained illegally or prescription opioids that have now come to an end, you've run out, for example, these are the symptoms that are going to occur. And typically, they will start to occur within hours and last for days. The withdrawal syndrome, anyways. So what are they? Well, agitation, sweating, piloerection are all the little hairs on your body are standing up on end. Severe abdominal cramping, diarrhea, really a feeling of impending doom. Okay, so we're going to talk about some medications that we use to help with withdrawal. So whether it's methadone or buprenorphine or clonidine, we can use some medications to help with the pain of withdrawal. So this slide is really just showing you a lot of the symptoms associated with opioid withdrawal, the abrupt ending of taking an opiate, whether it was prescription or illicit. So you're quitting cold turkey, well, you're going to have sweating, vomiting, diarrhea, dilated eyes, tachycardia, severe abdominal cramps. All those things are going to happen, right? And you're going to become quickly dehydrated. So these patients can come in severely dehydrated. I'm not sure why there's a child on the ceiling. If someone can tell me, just let me know. But I thought this slide just gave a lot of the symptoms of opioid withdrawal. Okay, so we looked at the first four there and spoke about benzodiazepines for acute alcohol withdrawal, naltrexone for abstinence used for alcohol or opioids, disulfiram. Don't take alcohol with it because you're going to have a severe interaction and make you sick. And then acamprosate for alcohol abstinence. And now we're going to move on and talk about buprenorphine, which is a type of opioid. Methadone, again, an opioid, a long-acting opioid actually. And then clonidine, which has been around for many, many years, probably 60 years, and that can be used for alcohol or opioid withdrawal. It's also used, as you've seen in a previous module, for attention deficit hyperactivity disorder. And originally, it's actually an antihypertensive medication. So you'll likely see it in that group when you learn about antihypertensives. And we're also going to review
and talk about some medications for smoking cessation, right? So nicotine replacement, bupropion, which is an antidepressant, but also used as a smoking cessation medication, and varenicline, which is Chantix, also used for smoking nicotine withdrawal or smoking cessation and abstinence, staying away from the cigarettes. Okay? Okay, so let's look at methadone. And methadone is really just an opioid, right? It's an opioid agonist, meaning it stimulates the opioid receptors just like morphine or codeine or any of the other opioids that we use. Okay, so why do we use methadone when someone is withdrawing from an opioid, or someone is trying to remain abstinent from uh, another opioid but is now taking methadone? You could ask yourself and say, well, really, they're just taking another opioid, so what's the difference? Well, there is a difference. So methadone allows some degree of assistance to take place while the person is taking the methadone and avoiding going into acute withdrawal. So to avoid that severe withdrawal that patients need to will endure if they don't take an opioid. And at the same time, they can receive counseling and help for their opioid addiction. So when methadone is started, it's given typically once a day. Remember, it's a long-acting opioid. So it's given once a day, whether it's for withdrawal or for maintenance of your opioid addiction. And then in a clinic, in a methadone clinic, the methadone can be gradually reduced while you are receiving ongoing counseling for your opioid addiction, trying to change your lifestyle, trying to alter some habits that have developed that are not healthy in your life, right? So methadone is often used for many, many months, right? And it's gradually reduced as the person is also trying to get their life in place. Okay? So there is definitely an advantage to using methadone. And when you're on methadone, you're typically having your urine checked for other opioid, for abuse of other drugs. And there's control of the doses with the methadone clinic that the patient is going to. Okay. So does methadone have adverse effects? Sure. So if you were to acutely overdose on methadone, it would be just like any other narcotic or opioid, right? So the respiratory depression, the hypotension, and finally cardiac arrest or respiratory arrest, because it's just an opioid. Now, methadone is very well known for its ability to prolong the QT. So it happens to be an opioid that prolongs the QT interval of the cardiac rhythm, and so many other drugs can interact with it because of that prolongation of the QT. Okay. The other ones that you see on there, the constipation, the dry mouth, that's all just from a typical opioid. Okay. The sedation, that's from a typical opioid. The QT prolongation is the more specific one for methadone compared to other opioids. And remember, we taper methadone very slowly over time. And the idea is to keep the patient off of an illicit opioid or narcotic that they're obtaining on the streets, for example, and they're now receiving help from a clinic and also remaining on an opioid that's gradually being reduced over months. So there's definitely an advantage to helping a patient and also titrating the opioid at the same time. Okay, so clonidine is just one of these strange drugs. It's not an opioid antagonist. It actually has nothing to do with opioids. It doesn't block them, but it's just been discovered over time when it was used with hypertension and ADHD, and just because it's been around for 60 years, it's been discovered that it can limit some of the effects of withdrawal, whether it's from alcohol or opioids. So starting someone on clonidine when they're in withdrawal can just help with some of those symptoms. It can reduce some of the symptoms. Okay? This drug actually works on the sympathetic nervous system, and we'll learn more about that in another module. But just remember that clonidine really started off as an antihypertensive. And in this particular setting, it can also be used to withdraw or help withdraw from alcohol and opioids. It has a lot of adverse effects. That's partly why we don't use it as much anymore. But it's sedating, and because it messes with the sympathetic nervous system, it can cause hypotension. It can cause bradycardia um, by inhibiting a part of the sympathetic nervous system. Okay, so we don't use it as much because of those reasons, and we're careful with it. And again, suddenly stopping clonidine can be a problem because you could get severe rebound hypertension um, uh, after stopping it. Okay, so we'll go into this medication more. Likely the most common side effect to this medication is that you're sedated a bit more, you have a bit of a dry mouth with this medication, and it has potential to cause orthostatic hypotension. Okay, so let's talk about buprenorphine, which is an interesting medication, and I think it's going to become more and more commonly used. So buprenorphine is used for opioid withdrawal, at least some of the process of opioid withdrawal, and I'll explain that in a minute. And also for someone who's withdrawn from an opioid, but now needs some kind of opioid in their system that they can gradually taper from. So it kind of sounds a bit similar to methadone, but it's safer than methadone. And that's because it's only a partial agonist, meaning it only partially stimulates the receptor, the opioid receptor. So that makes it much more difficult to overdose on this medication because it only has partial agonistic effects. Okay? But by having partial agonistic effects, it blunts some of the withdrawal symptoms, meaning as you withdraw from a full agonist, such as heroin or morphine, you can add something like buprenorphine or buprenorphine and naloxone to have partial stimulation of the opioid receptors and much less withdrawal symptoms. And as well, you can maintain someone on this after they've withdrawn. Okay? So what are the main adverse effects to this medication? Well, they're going to be mainly similar to an opioid, because that's what it is, right? It's a partial agonist. So it has partial opioid effects. So sedation, nausea and vomiting, constipation in very high doses, but it's much harder to overdose on this because it only has partial effects. Respiratory depression, itchiness, which is pruritus, which is any opioid can cause that. And sweating. Any opioid can cause diaphoresis. Okay? So how is this medication used? Well, if someone comes in and they're already on um, a full agonistic opioid such as heroin or morphine, well, you can't just replace those with this one, because what's going to happen is they're going to go into withdrawal immediately, because this only has partial agonistic effects. So they'll go from a full agonist like heroin or morphine, and if you were to replace it before they even went through a bit of the withdrawal process, you would put them in acute withdrawal with this drug. So they have to be in some degree of withdrawal already before starting this medication. Okay? So, and then they can continue on this medication as the opioid that they'll receive at a clinic. Okay? So what's the advantage of this over methadone? Well, it's safer because it causes less respiratory depression and less dependence because it's only having partial effects. Okay? What's the reason for having naloxone in this oral medication? Because naloxone, by the way, does not get absorbed by the gastrointestinal tract. So whenever we use naloxone by itself, say for to reverse an opioid overdose, it's always given intravenously. So what's the advantage of adding naloxone to buprenorphine? Well, if you take it as a pill, there's no difference at all. It's the same as buprenorphine because naloxone never gets into the bloodstream. But say someone's given buprenorphine and they take advantage of the medication by crushing it, maybe liquefying it and injecting it into their bloodstream, well, they're going to have morphine-like effects from the drug, right? What if they take buprenorphine with naloxone added and inject it into their bloodstream by having crushed it and liquefied it? Well, there's naloxone in it, and that's a complete blocker of opioids. So in actual fact, it'll have no effect at all. So the buprenorphine will be blocked by the naloxone if it's taken advantage of in the IV form. So in the oral form, no problem. They're the same, buprenorphine or buprenorphine naloxone. So Subutex or Suboxone would be the same. If taken advantage of, the naloxone will block the effects of buprenorphine, and patients or clients will be less tempted to turn it into an IV drug because they know the naloxone is in there. Okay, so it reduces the potential for abuse when someone is starting on this medication for opioid withdrawal. Okay, so let's just look at a couple of antidotes here. So benzodiazepines have a full antidote called flumazenil. So if someone comes in an acute benzodiazepine overdose, what's the first thing to do? Airway, breathing, circulation, right? There's no sense in running for the flumazenil if someone isn't breathing. So airway, breathing, circulation, and then Sure. Get the flumazenil so that we can reverse the effects of the benzodiazepine, which are often respiratory depression, decreased level of consciousness, and potentially hypotension. Okay? What about a opioid overdose? So someone comes in having taken too much intravenous fentanyl on the streets, for example. Fentanyl is an intravenous drug typically used in a hospital, but it's also sold on the streets. What happens if you take an overdose of an opioid such as fentanyl? Decreased level of consciousness, hypotension, and definitely respiratory depression, and that's often the cause of death, respiratory arrest. So again, it will be airway, breathing, circulation control first, and also somebody would be going to get the naloxone to reverse the the opioid effects. And remember, with opioid overdose, we look at the eyes. We want to see if they have constricted pinpoint pupils, because that's very classic in an opioid overdose, along with being heavily sedated or unconscious, breathing very slowly, and hypotensive. Okay? Acetaminophen overdose. Well, acetylcysteine is the antidote. Extremely effective in an acute Tylenol or acetaminophen overdose where someone has taken a massive amount of acetaminophen. Acetylcysteine protects the liver from toxic metabolites, and patients typically don't get liver failure if the acetylcysteine is given within hours. So very, very effective antidotes. Okay, so let's move on to some medications to help with smoking cessation. Okay, so here's just an image of all the chemicals that are in a cigarette, which is really amazing. Actually, there's more than these that are in a cigarette. So you can see there's arsenic, carbon monoxide, which binds to your hemoglobin and makes it difficult for oxygen to bind to your hemoglobin. There's ammonia, which is toxic to the body. All kinds of very, very toxic chemicals in a cigarette. And really, what we're trying to do with the medications that we're going to talk about is to help with the withdrawal, often of the nicotine component, okay? Because nicotine is extremely addictive. Okay, so this slide I'm going to leave it's just a reading slide about the symptoms or side effects that people get from nicotine withdrawal, right? The restlessness, the irritability, the mood swings, the difficulty concentrating. Very common in smoking cessation, cold turkey in particular. And when we look at people that have quit smoking, it makes a significant difference to their health. So, for example, if you can quit smoking prior to it causing permanent damage, such as emphysema or heart disease, your risk of many conditions reverse back to a normal non-smoker risk, such as the risk of developing lung cancer. That after 10 years, your risk goes back to being that equal to a non-smoker. Okay? So it's very important to discuss smoking cessation with patients. In fact, prior to a surgery, patients are often advised to try and quit smoking for any general anesthetic, because the anesthetist will know that even 2 weeks of quitting smoking can vastly improve lung function and circulation in the body. Okay, so nicotine withdrawal. What are the symptoms of withdrawal and abstinence? Initially, when you stop smoking, the irritability, nervousness, restlessness, insomnia, difficulty concentrating. Well, this is where the medications come in to try and help those symptoms so that you have more success at quitting smoking. So we're going to review bupropion, nicotine replacement therapy, and varenicline. So first one here, bupropion, is a well-known antidepressant. And we discussed this in the antidepressant module. It is also, and as an antidepressant, it is known as Wellbutrin, which is the brand name. As a smoking cessation medication, it's called Zyban as the brand name. And really this came about while this medication was being used as an antidepressant. It was realized that the urge to smoke was decreased in patients that were receiving this medication for depression. And after some research and studies, it was felt that this medication was effective as a smoking cessation medication. So let's look at the adverse effects of taking bupropion, whether it's for depression or whether it's for smoking cessation. So it's an activating drug, meaning it can lead to restlessness, insomnia, potentially seizures if you have a seizure disorder, tachycardia, nervousness, lack of appetite, hypertension. So it's activating. So for example, if someone was already anxious or had an anxiety disorder, it likely wouldn't be a good idea to also start bupropion. It can activate someone. Okay. Now, in terms of smoking cessation, there's definitely been some success using bupropion for weeks to months to reduce the urge and desire to smoke. And often the way that it's started is that you start with a smaller dose of bupropion while you're still smoking, and over the span of a week or 10 days or 2 weeks, you increase the dose of bupropion as you are tapering off your cigarettes. Okay? And often the urge to smoke is diminished while on this medication. Okay, so varenicline is another medication used for smoking cessation. The brand name is Chantix. I don't think we need to get into the action too much. Main side effects, nausea can be a common one. Most people tolerate this medication quite well. Some people can have abnormal dreams. They can have nightmares. There's been some concern about depression and suicidal ideation with the drug. Relatively uncommon. Okay. Typically contraindicated in patients with mental illnesses such as schizophrenia, bipolar illness, because this is affecting dopamine in the brain. Okay, can lead to a bit of a dry mouth, so chewing gum can help that, and avoiding CNS stimulants such as caffeine or any other CNS stimulants. Okay, so this can be also an effective smoking cessation. So We often look at the 1-year success rate of these different medications, and varenicline tends to be one of the most successful of the medications that we've spoken about, whether it's bupropion or nicotine replacement. Okay, so nicotine replacement. So what is the chemical that you withdraw from when you stop smoking? It's the nicotine. So we can replace that with a patch, with gum, with an inhaler, nasal sprays, lozenges. And often with the patch, for example, they'll come in different doses. So we can start with a full dose patch, and then weeks later it can be reduced to a mid-dose patch, and then finally to a lower dose patch. And typically you'll choose your quitting date of cigarettes, and you'll apply a patch from that day on for weeks to months. Okay, so it helps with the urges and cravings that patients get as they're withdrawing from nicotine. So I won't spend too much time on nicotine replacement. There's a lot of information in the notes, but just to know that these are commonly used for smoking cessation. Okay. Now, nicotine can, in large doses, nicotine can cause headaches, nervousness. It can increase your heart rate, can cause hypertension. So it can have some stimulating effects. Okay? It's advised not to use these products in pregnancy, which is reasonable since you really don't want someone who's pregnant taking nicotine that is going to be transferred through the placenta to the fetus. If someone is smoking, not only are they transferring nicotine, but they're also transferring many other chemicals to the fetus. So it's not uncommon to see someone on a nicotine patch when they're pregnant, even though it's not recommended for pregnancy. It's certainly better than smoking cigarettes, since it's really only nicotine instead of all the other chemicals and carcinogens that are in cigarettes. Okay, so next slide is about electronic cigarettes. Not all of them have nicotine in them, but many of them have nicotine as a replacement instead of smoking. And these are not FDA approved products. So the typical advice for these is, if you're a non-smoker, don't start taking these. Why get addicted to nicotine? If you're a smoker and you can switch to these, that's beneficial on your way to quitting the electronic cigarette as well. Because the electronic cigarette at least doesn't have all the other toxins and carcinogens that cigarettes do. So that's the general consensus now, that if you're a non-smoker, don't start taking these. If you're a smoker and you want to transition to quitting smoking, this could be an alternative to get away from combustible cigarettes, right? Which have so many carcinogens in them. Okay, so let's move on to another topic. We're going to talk about some neurological conditions and some medications that we can use to help patients with their chronic neurological conditions. Okay, so the idea is to help symptoms and to maintain a patient's activities of daily living, their ADLs. All right. So the intention is not to cure the chronic neurological condition. It's to help alleviate some of the symptoms. Okay, so degenerative diseases of the central nervous system, we call neurodegenerative diseases, right? So the nerves are degenerating. And these are progressive. They're not reversible. They just gradually get worse and worse and worse as time goes on. And many of them we don't know the exact cause of many of them. Some of them have genetic components to them, and some of them have environmental causes. And we'll come to that as we talk about each one. So let's carry on here. So as I mentioned before, the idea of medications for these diseases is really symptom control and maintenance of function. So function of daily living or activities of daily living. Okay, there's no intention of a cure with these medications. So let's go and start with the first neurodegenerative condition. So Parkinson's disease is a condition of a small part of the brain called the substantia nigra. So this part of the brain is responsible for movements. So it's involved in controlling and helping with fine motor movements. Typically, Parkinson's occurs around the age of 60 or older, with men being more commonly affected than women. And it's felt to be a deficiency of dopamine and an excess of acetylcholine in the substantia nigra. Okay? And remember that because that's where the medications are going to be aimed at, either increasing dopamine or reducing acetylcholine to help with the symptoms. And this is a chronic degenerative process over the span of years and sometimes even over a decade, right? So it's not within a year that someone develops Parkinson's and typically dies of Parkinson's. It's over the span of many years to the point where they become immobile, bedbound, or they have a fall and fracture a hip, or they're bedbound and develop a pneumonia, which ends up killing them. And late stage Parkinson's, you can develop dementia. Okay, so if you look at the picture on the right or the diagram, these are classic symptoms of Parkinson's. The very flat facial expression, stooped posture. All the muscles are very rigid. So if you were to move this person's elbow, flex and extend this person's elbow, it would feel very rigid. Okay. They don't typically swing their arms like an average person does. And they shuffle, they have a shuffling gait. They don't lift their feet up, they shuffle along, which puts them at very high risk of falling or tripping on something or catching their foot on a carpet and going down. And then also the hallmark of Parkinson's is a resting tremor. So when you look at their thumb when they're resting, it constantly has a resting tremor to it. Okay. Most of patients with Parkinson's have idiopathic degeneration. We don't know the exact cause, but that's the vast majority of patients with Parkinson's disease. You may have heard of Parkinson's disease in Muhammad Ali. that was felt to be from recurrent head injuries, that would be relatively uncommon. By far the most common is idiopathic. We just don't know. We think there may be a bit of a family history to it, so a possible genetic link, but it's not absolute that if your parents have Parkinson's that you will develop Parkinson's. So a progressive destruction of the neurons in the substantia nigra is the cause of Parkinson's disease. Okay, so this just goes through the cardinal symptoms and signs. So a resting tremor. When you see an older person sitting there and their thumb is constantly moving back and roll like they're pill rolling. So between their thumb and their index finger is constantly going back and forth in a circular motion. That's called a pill rolling resting tremor. Okay, and that's classic for Parkinson's. Muscle rigidity, is the stiffness when you try to move their arms or their legs. Very stiff as opposed to nice, soft, smooth muscle movements. Okay? Very, very flat appearance when you look at them, at their face. They don't really smile. They don't really frown. It's just very flat. Okay, and it's not because of their mood, it's just lack of facial motor activity. Okay, and as it progresses, they can develop drooling because of lack of facial motor activity as well. Okay, so bradykinesia means slow movements. So they eat slowly, they swallow slowly, they speak slowly, and they walk very slowly. So a lot of patience is required in clients with Parkinson's disease because everything is done with very slow motion. Okay, the shuffling gait, again, big risk factor for falling. And they already tend to be very unstable because they have a stooped posture, and they don't have great coordination anymore. So they are already unstable, so it's difficult for them when they start to trip on a carpet, for example, to catch themselves. They typically just fall. Okay, and that's where we come to postural instability. Stooped over, difficulty maintaining a normal balance, frequent stumbling and falls. Okay, so patients with Parkinson's often fall. Okay, so this slide is just showing you where we're concentrating on with Parkinson's disease. It's the substantia nigra, which are these dopamine producing cells that start to degenerate, and they were responsible or are responsible for fine motor activity. And when they start to die, certain obvious symptoms and signs develop that are related to fine motor activity. This next slide will help you visualize what the different medications are attempting to do. So it really comes down to two things. Can I make a drug that increases dopamine that can have an effect on the dopamine receptors? And there is a medication like that. Can I make a drug that mimics dopamine? And there's a medication like that. And can I make a drug that stops the breakdown of dopamine? And there's a medication like that. So it's either improving dopamine delivery or a drug that can mimic dopamine to stimulate the dopamine receptor, or a drug that will prevent the breakdown of dopamine. And remember, some of these medications are used in combination. It doesn't need to be necessarily one drug. Okay, so there's one classic drug for Parkinson's disease. Other ones are added as the initial medication starts to wear off and becomes less and less effective as the disease progresses. Okay, so here is definitely the prototype drug for Parkinson's disease, levodopa carbidopa. So the main active ingredient or the chemical in this drug called Sinemet is levodopa. And I'll explain why carbidopa is in there. So this is definitely an anti-Parkinson's drug. It's also used for restless leg syndrome, which people can get where when they're trying to sleep. It's a neurological condition, and it's kind of an interesting condition. It's where someone is trying to sleep, but it feels like their legs are just not stopping. It feels like they're running when they're trying to sleep. And it's very distressing because it's hard to fall asleep when your legs always feel like they're moving. And because it's a neurological condition, it's not a muscle condition, it's felt to be a neurological condition, levodopa has been used for it with success. So that's why you see it under the indication. But really, this medication mainly for Parkinson's disease. And why is that? Is because levodopa is converted to dopamine in the brain, and it increases dopamine levels. So remember that slide we just spoke about of what is this drug doing? Well, this one just delivers more dopamine to the synapse because levodopa is converted to dopamine. Okay? The main adverse effect of this drug is nausea and vomiting. And it's really dose dependent. So as you go up in the strength of these medications, or this one in particular, nausea and vomiting becomes more common. Okay? You can also get sedation with this medication. Okay, so it can be quite sedating. Dyskinesia, so that means abnormal movements. And why do you get abnormal movements? Well, it's because you're increasing dopamine in the brain, and in particular in a part of the brain that is responsible for motor movements, so muscular movements. And if you don't get the dose right on, or if there's too much or too little, you can get dyskinesia, meaning abnormal motor movements as a side effect to the drug. Because this converts to dopamine as well, it can play around with the autonomic nervous system, and you can get orthostatic hypotension, meaning if an older person stands up too quickly on this medication, their blood pressure can drop. Psychosis, well, if you remember from a previous module, schizophrenia and psychosis is felt to be from excessive dopamine levels. So levodopa is increasing the dopamine in the brain, so it can lead in large doses to psychosis. Okay. And lastly, you can get a bit of discoloration of the sweat and urine. That wouldn't be a reason for stopping the medication. Okay, so this medication is often taken 3 times a day, sometimes 4 times a day. It's taken with meals. And what can happen over a period of time is loss of effectiveness, this wearing off syndrome, where a patient with Parkinson's is taking levodopa carbidopa, and when they're walking, they suddenly have this wearing off syndrome where the medication is just not lasting very much or very long anymore. and they can have these freezing episodes where they just suddenly can't walk. That can be very distressing. So sometimes the dose can be adjusted upwards to try and help with this on-off syndrome of motor activity, or another medication needs to be added to increase dopamine in the substantia nigra. Okay? So the main aim of this medication is to maintain activities of daily living, maintain some mobility, and help with all of those symptoms that you saw in the diagram of that older patient, and the symptoms that he has. Okay, so the tremor, the stoop posture, the shuffling gait, the bradykinesia can all be helped with levodopa carbidopa. Remember that it can wear off over time, and a second medication can be added. Okay, so why the carbidopa? Levodopa is broken down very quickly in the bloodstream. So when this drug was being researched many years ago, someone added a chemical called carbidopa, which is broken down in the bloodstream and in the liver, sparing the levodopa, allowing higher levels of levodopa to be maintained in the bloodstream and getting to the brain. Levodopa by itself would break down very quickly if it wasn't for adding the carbidopa. Okay, so carbidopa has no effect in the brain. It's to stop the breakdown of the levodopa. Okay, so this next medication, pramipexole, is just a dopamine agonist. It mimics dopamine and stimulates the dopamine receptors. And in that way, it can be effective for Parkinson's disease, and it can also be used for restless leg syndrome, but really the main indication is Parkinson's disease. The adverse effects, difficulty staying awake, so daytime sedation is an adverse effect. It can cause insomnia, difficulty sleeping, and dry mouth. So those would be the main ones. Psychosis is possible, so inducing hallucinations in someone can occur because you're increasing dopamine levels. So those are the main ones. Impulse control, there have been reports of people with increased sexual desire, increased desire for gambling. So that is an adverse effect, but much less common. I would concentrate on the common ones. So daytime sedation, insomnia at night, the potential for hallucinations, meaning psychosis, and even the orthostatic hypotension is always a good idea to remember, since that's a common one with levodopa carbidopa as well. Okay, so this one can be added to levodopa carbidopa as the first medication is starting to have less effect. This one can be used to augment the effects of levodopa carbidopa. Okay, so here's a bit of a strange medication for Parkinson's disease. A medication that was originally used as an antiviral medication for influenza A, although it's currently not recommended to be used for influenza A any longer, and can still be used for Parkinson's disease, since it has the potential to increase dopamine in the synapse, all over the body, but also in the substantia nigra. Okay. Now, this medication doesn't come without significant side effects, and they're mostly related to the central nervous system. So, confusion, sedation, dizziness. There's a significant chance of having a fall in the elderly on this medication. So, again, when we hear about those types of side effects, we're much more careful using these medications in older patients, especially when they already have difficulty maintaining their balance and walking, such as with Parkinson's disease. So amantadine can cause a lot of CNS symptoms, which makes it a less useful medication. And again, this medication can be used in combination with levodopa when that particular medication is wearing off. I think the main thing to remember about this is that yes, it's a Parkinson's medication. Yes, it has significant side effects, CNS side effects, and that it's really not used very commonly for that reason, and it's basically not used at all for influenza A any longer. This next medication, entacapone, I think just referring back to that slide that showed the different areas where drugs can work for Parkinson's will help you. This inhibits the enzyme that breaks down levodopa. So by inhibiting that enzyme from breaking down levodopa, it allows increased levels of levodopa, which will then lead to increased levels of dopamine. And the plan is to have increased levels of dopamine in the substantia nigra. This will do it also in other parts of the body, since an oral medication cannot just act in one area. And the main adverse effects to a medication that's increasing levodopa levels will be vomiting and diarrhea, plus associated symptoms from the abdomen, such as abdominal pain, and as well, this one commonly causes a dry mouth. And like levodopa, carbidopa can lead to some sedation. Okay, so if you were to put that together, you would think of abdominal pain, vomiting, diarrhea, and sedation, plus dry mouth as the most common side effects to this medication. Now, it can also cause dyskinesia. Remember, what are we doing with these medications is that we're increasing dopamine levels in the brain. And that can lead to abnormal motor movements. And that's what dyskinesia means, right? Dys is basically abnormal. Kinesia is movement, abnormal movements. And whenever we start to play with neurotransmitters, especially one that is controlling motor movement, we can have abnormal movements. And lastly, sure, you can have discoloration of the urine, kind of an orangey yellow color in about 10% of people. That's not an important adverse effect. It has no clinical relevance. Sorry. So maybe mentioning it is worthwhile so that the patient isn't surprised, but it doesn't cause any harm. So I think when you start to look at medications in this group, there's going to be a lot of similarities in their side effects because of the fact that you're increasing dopamine in the brain. Okay, so when you look at levodopa carbidopa and you look at this particular medication, there's going to be similarities to the adverse effects because of what they're doing. Okay, this next medication you've seen or you've heard of before, called benztropine, and it's a medication that we can use for patients on antipsychotics that are having extrapyramidal symptoms. So stiff muscles, dystonia, akathisia. We can treat them with an anticholinergic, such as benztropine or diphenhydramine. And remember, because of the low dopamine levels in the substantia nigra, you develop increased acetylcholine levels. So treatment can also be aimed at the increased acetylcholine levels with anticholinergics. And here is one of them, benztropine. Okay? So it blocks the effect of the cholinergic system that has occurred because of the reduced dopamine levels. All the side effects are going to be from anticholinergic. So, what are anticholinergic side effects? Blurry vision, sedation, dry mouth, constipation, inability to urinate. So, just think of those when you hear the word anticholinergic. Okay? Blurry vision, dry mouth, sedation, constipation, urinary retention are some of the very common ones. So you can imagine that can make it difficult for older patients to take because of those anticholinergic side effects. Okay, and lastly, selegiline. So again, this is a medication that has its effect by preventing the breakdown of dopamine. So it's a monoamine oxidase inhibitor. You've heard that term before with those older antidepressants, the MAOI inhibitors. This is similar. So it prevents the breakdown of dopamine, allowing for higher levels. If you prevent the breakdown of dopamine in the body, you're going to have side effects that are predictable. The gastrointestinal tract, so nausea, vomiting, diarrhea, the potential to induce hallucinations, i.e. psychosis, dyskinetic movements because of the increase and decrease, because remember, this drug goes up and then comes down again. So it's not really behaving like normal dopamine levels without this disease. So you get abnormal movements as the dopamine goes up and down. This medication, by the way, can also be used as a patch for depression. Remember, it's an MAOI inhibitor, so it is used as a patch for depression as well. Okay? Now, this is often combined with levodopa because what does this drug do? It prevents the breakdown of dopamine. And what does levodopa do? It increases the level of dopamine. So by stopping its breakdown, there's more dopamine in the synapse. And sometimes the medications, when used in combination, have to be adjusted because there's just too much dopamine in the system that's causing the gastrointestinal side effects, the potential for hallucinations and confusion, potential for loss of balance. So all of these things can happen, especially now that you're combining two medications that are increasing dopamine levels in the end. Okay? Okay, so let's move on to another neurodegenerative disease, and that's Alzheimer's disease or Alzheimer's dementia. And Definitely dementia is the hallmark of this disease, and short-term memory loss is definitely the initial symptom of this disease. So it's progressive short-term memory loss. Patients with Alzheimer's disease often retain long-term memory until towards the end of their disease. Okay, so typically you will recognize someone with Alzheimer's dementia because of short-term memory loss. They forget where the keys are. They forget a recent conversation. They forget where they parked the car. Those are all short-term memory abilities. And then the inability to think properly, to cognitively cognitive processes are impaired. So, for example, the ability to pay a check and put it in the mail, the ability to communicate, whether it's by letter or email, that is starting to be lost. But really, the first early sign, short-term memory loss. We don't know the exact cause. We do think there is a genetic component to it, plus an environmental component. We really don't know the exact cause of this. There's definitely structural changes that occur in the brain. There's thinning of the cerebral cortex that you can see in the image here, where the amount of neurons look vastly diminished. So it's thinning on the right side. And because of the thinning, other parts of the brain, such as that ventricle, which is really just where cerebrospinal fluid flows, become enlarged because the tissue part of the brain is gradually degenerating. So what is the current research telling us about Alzheimer's disease? We think that it's a deficiency of the neurotransmitter called acetylcholine. And you will have heard of acetylcholine before because that's a neurotransmitter in the parasympathetic system. Now, just because it's a neurotransmitter in the parasympathetic system doesn't mean that it can't be in other parts of the brain, because it certainly is, just like dopamine, just like serotonin. So neurotransmitters are definitely in more than one location in the brain, and it's felt to be a deficiency of acetylcholine in this particular disease called Alzheimer's disease. Early onset would definitely be considered early, between the ages of 30 to 60, since most people that develop this disease are typically over the age of 65. So the typical onset for Alzheimer's disease, we feel is likely has a genetic component plus some kind of environmental component. So whether it's oxidative stress, remember we spoke about antioxidants. So we think possibly just over time and what's called oxidative stresses to the body, there's degeneration of the neurons. Okay? And remember, short-term memory loss. So patients don't usually forget the names of their children, the names of their spouse at the beginning. Those are typically very late findings and symptoms in Alzheimer's disease. Okay, so let's look at some of these medications that are all very, very similar in how they work and all have very, very similar adverse effects. And I'll explain why. So whether we're talking about donepezil, which is Aricept, rivastigmine, Exelon, and galantamine, Razidine. They're all very similar, and most of these drugs don't have a highly effective improvement in patients with Alzheimer's disease. So they may increase short-term memory a bit, but not to any significant degree. So it's all that's available right now. If somebody would want to try or like to try a medication for Alzheimer's, but remember, not very effective. If they were effective, most of you would have heard about these fantastic drugs that reverses someone's memory loss, and that isn't the case. So what do these drugs do? Well, there's an enzyme in the synapse called acetylcholinesterase, and its job is to break down acetylcholine once it's sent a signal across to another nerve. These drugs block that enzyme from breaking down acetylcholine, which increases acetylcholine levels in the synapse. And we think that effect is how the short-term memory can slightly be improved upon in someone with mild dementia. Well, what other system works with acetylcholine? Remember, these are oral medications. So this drug goes everywhere. What other system works with acetylcholine? The parasympathetic system. You are going to stimulate and increase acetylcholine levels in the parasympathetic system. What's that going to do? Increase saliva, increase nausea, increase peristalsis and abdominal cramping, vomiting, diarrhea, because you've turned on the parasympathetic system by increasing acetylcholine. So these are very poorly tolerated medications. A large percentage, 15–20% of patients will have gastrointestinal side effects, and you can see them on all of them in this slide at the bottom. Nausea, vomiting, diarrhea. Nausea, vomiting, diarrhea, loss of appetite. Nausea, vomiting, diarrhea, loss of appetite again. So you can imagine an older person having to endure nausea, vomiting, diarrhea, and loss of appetite. Not a great medication. And the effects that you're looking for, so the therapeutic effect, is very limited. So you can see these medications as a group because they really all do the same. They work through the same mechanism. Okay, so I won't spend too much time on this other medication for Alzheimer's dementia. Remember, whichever drug we're talking about for Alzheimer's dementia, we're really looking for small improvements. We don't see huge improvements with these medications with dementia, unfortunately. Okay, maybe one day there'll be a medication where we'll see a significant improvement in activities of daily living and gaining back memory. But really, in general, we're looking for really small incremental improvements. So not overly effective. Okay, so memantine is the one drug that really doesn't work the same as the other drugs for Alzheimer's. The other ones are acetylcholinesterase inhibitors, and they raise acetylcholine levels in the brain, since we think that one component of Alzheimer's disease is an acetylcholine deficiency in the brain. Okay, so this one works quite differently, and you'll notice that the side effects are quite different. I mean, some of them are similar, such as the nausea and vomiting, but the other ones are quite different. Okay, with the acetylcholinesterase inhibitors, it was almost all gastrointestinal side effects. It was nausea, vomiting, diarrhea. Um, uh, when we were talking about donepezil, okay, this one not so much. There's some neurological symptoms. There's confusion, dizziness, combined with some gastrointestinal symptoms. Okay, so I think if you're just recognizing this drug and you realize that yes, this is a drug to try and improve memory, try and improve activities of daily living in someone with Alzheimer's dementia, I think you're doing fine.
Okay, multiple sclerosis, we're not going to spend too much time on this. It's a demyelinating disease of the central nervous system where the myelin is gradually destroyed. We think it's an autoimmune disease. And when you destroy myelin on neurons, which wraps around the axon and allows for fast conduction of impulses of nerve signals, then you get specific symptoms based on where the myelin is broken down. So the symptoms will really be based dependent on where the myelin is damaged. And that's very hard to tell. People come in with multiple symptoms. That's why we call it multiple sclerosis, because of all the varied symptoms that somebody could present with initially, and that makes it very hard to diagnose um, when they initially present. So in multiple sclerosis, if we were to maybe choose what's called a classic presentation, it would typically be a 20 to 40-year-old female who presents with blurry vision since the nerves from the eye are being affected, weakness since some of the nerves to specific muscles are being affected, and bladder incontinence. So that would be a classic presentation of multiple sclerosis. Not necessarily that common though, because it really depends on where the myelin is breaking down. This is typically a gradual decline in function with this disease, but some patients can decline much, much faster than others. So some patients can maintain function and activities of daily living for many, many years. Others decline much more rapidly. Okay, so let's just talk briefly about what we can use for multiple sclerosis. So it's not on this slide. I think it's probably on your slide for class. But one group of medications that we use, and we won't have a prototype for this condition, are interferons. And you may have heard of interferons already, since your body already makes interferons. Your immune system uses interferons to communicate with each other. And interferons can then be produced in a lab and injected into patients. So remember, interferons are proteins. You can't take protein medications by mouth because your digestive tract breaks them down. So they're injected, and they can help slow down the progression of multiple sclerosis. Okay, so they would be used on a more long-term basis. For someone who presents with an acute flare-up of multiple sclerosis, such as they have return of their blurry vision, return of bladder incontinence, we can use very high doses of corticosteroids intravenously, typically for 3 days. So this
What this does is it suppresses the immune system. Remember, we think this is an autoimmune disease. So by suppressing the immune system, we can treat acute exacerbations of MS with intravenous steroids. Okay, so let's spend the next half hour going through this slide. And we're going to start in the top left-hand corner where you see CD8. And I'm kidding. Okay, this was just added for a bit of comic relief amongst all these drugs.
Okay, so let's talk about amyotrophic lateral sclerosis, which is better known as Lou Gehrig's disease. And this is a disease of the motor neurons. Okay, so the neurons that go from the spinal cord to the muscles of the body. And there is destruction of these neurons, leading to profound weakness of all the skeletal muscles in the body. So whether it's the arms, the legs, the forearms, swallowing, and of course respiration. So it spreads to all the skeletal muscles due to the neuronal destruction, which is really quite a sad disease because typically the brain and cognition remains intact. And it's often a downhill course over the span of 2, 3, 4 years due to respiratory failure, recurrent lung infections, and recurrent pneumonias. And there's really there's no cure for this disease. Some people end up on a respirator to prolong life, and other people unfortunately die from respiratory failure. Okay, so we'll spend 30 seconds on this medication, Riluzole. And really, it's a medication that isn't very effective at all. There will be no prototype slide on this medication. In one study, it showed a 2 to 3 month extension of life. It's felt to potentially reduce the degeneration of the lower motor neurons. Remember, those neurons that go from the spinal cord to the muscles. So there's really minimal benefit for amyotrophic lateral sclerosis. So really just to know the medication, Riluzole, but we're not going to get into any details about it at all. Okay, so let's move on to the next chapter, which is muscle relaxants. And the way to think of muscle relaxants and muscle spasms are there is acute muscle spasms where someone has either lifted something too much or twisted in a wrong way, and they have an acute sudden onset of a muscle spasm, typically in their back. And then there's a medication that we use for that called cyclobenzaprine. We'll get into that. And then there's other conditions where you want to try and relax the muscles because of spasticity, because they have chronic muscle spasms due to the condition they have. And that's typically along the lines of post-stroke, cerebral palsy, a spinal cord injury, where the muscles have become rigid and they're starting to lead to what are called contractures of the joints, meaning they're not able to move their joints very well because the muscles are so stiff. So whether it's being able to flex and extend the elbow, or flex and extend the wrist, it's due to the central nervous system disorder that they have. So we'll talk about acute muscle spasms and more chronic muscle spasticity. Okay, so before we get into this slide on diazepam, when we're talking about medications for muscle spasms, there are medications that are centrally acting, meaning they work on the brain to cause relaxation of the muscles. And that will be most of them. And then we'll talk about a medication that works directly on the muscle itself to cause relaxation. Okay? So when we look at diazepam here, which is really one of many benzodiazepines, we've put this slide here just to remind you that we can use this for muscle spasms, right? It works through the GABA system, that inhibitory system of the brain, and it can lead to acute muscle relaxation. So immediate muscle relaxation. So if somebody comes in with acute back spasms from, say, an injury or from lifting something that was much too heavy for them, we can use diazepam to relax those muscles. We typically don't leave people on a benzodiazepine for muscle relaxation because it also relaxes the brain so much. It causes so much sedation. So for acute muscle spasms, it can be very useful. I'm not going to go into all the adverse effects on diazepam because we've discussed it before, and all the benzodiazepines are so similar. Okay, they'll all have the same indications. They'll all have the same medications to avoid, such as alcohol, opioids, and always being careful with airway, breathing, and circulation when someone is on intravenous benzodiazepines. Okay, so let's move on to another medication called baclofen. It actually works through the same system as benzodiazepines, which is the GABA system. And really, its expected therapeutic effect is to lead to muscle relaxation and reduce muscle spasticity in conditions such as multiple sclerosis, cerebral palsy, and spinal cord injuries. So we typically don't use this for acute muscle spasms, say, of the back. It's more of a long-term daily dosing medication for muscle spasms. Okay, and here's the information or the prototype slide on baclofen. Again, working through the GABA system, the inhibitory system. So it works through the central nervous system to help muscle spasms in neurological spastic disorders such as cerebral palsy, and spinal cord injuries or multiple sclerosis. Okay, it definitely has some anticholinergic side effects, so it can lead to a lot of sedation. Okay, and if we also look at other adverse effects, remember anticholinergic effects, nausea, constipation, urinary retention are all anticholinergic side effects. So making sure that someone drinks a proper amount of fluid and that they're on a high fiber diet on this medication because of the constipation. There's also the potential for baclofen to aggravate a patient with seizures. So that doesn't make intuitive sense because it suppresses the GABA system, but there is potential for someone who has a seizure disorder to have more seizures while on this medication. So it's something to consider or to avoid with someone who has a seizure disorder. Okay? And remember, because of its sedating effect, to avoid alcohol, barbiturates, and opioids. So baclofen, what's the therapeutic effect or the expected effect is to reduce muscle spasticity. What are the significant adverse effects? All those anticholinergic side effects we've spoken about: blurry vision, dry mouth, constipation, urinary retention, sedation are all also included with baclofen. And then, of course, the potential to cause seizures. Okay, so what about this next medication, cyclobenzaprine? So this will be the prototype slide, say. So just because I don't think we need too much more information on it. So cyclobenzaprine, or the brand name Flexeril, is used as a muscle relaxant for acute muscle injuries. So acute muscle pain of the back, for example. It's also centrally acting, so it's going to have those sedative properties, just like baclofen. And it's used for a short period of time, right? So a few days for an acute muscle spasm, not long term. Now, because it has a lot of anticholinergic side effects, look at the side effects on the right side of this slide. So dizziness, drowsiness, tachycardia because it's anticholinergic, off balance, ataxia, and the abdominal distress is all going to be because of constipation, heartburn, and nausea and vomiting. So really it has a lot of anticholinergic side effects. They should probably include potential to fall in elderly people, avoid with other sedating medications or alcohol. So yes, it's centrally acting to try and help acute muscle spasms, not an overly effective medication. So let's talk about dantrolene, which is the one medication for muscle spasticity that works peripherally. Okay, it works directly on the muscles, and it inhibits contraction of the muscles by stopping calcium release in the skeletal muscles. So really the idea behind this medication is to reduce spasticity in cerebral palsy, spinal cord injuries, or conditions such as multiple sclerosis. It's also used to treat that rare condition of antipsychotics called neuroleptic malignant syndrome. And we do have a slide of that if you went back to the module on antipsychotics. Now, you're not going to see the same degree of anticholinergic effects with this drug because really it acts directly on the muscle as opposed to through the GABA system of the brain and causing sedation and all the other CNS side effects. So mainly it's going to be hepatotoxic. It can cause a hepatitis. So all of those symptoms after the word hepatic toxicity are related to hepatitis. So don't only know the term hepatic toxicity, know what the symptoms are of hepatic toxicity. Anorexia, potentially right upper quadrant abdominal pain. Jaundice, which is increased bilirubin from the liver damage. Okay? So, in order to use this medication, we typically will obtain liver function tests and repeat them occasionally to make sure that the liver is not being irritated or inflamed by this medication.